Yes, good morning, ladies and gentlemen, once again. We are going to have a discussion on gestational trophoblastic diseases. Very, very nice, and something that is common. You several times notice that there are patients you are evacuating because of incomplete abortion, because of blighted ovum, because of missed abortion. Sometimes this patient has gestational trophoblastic disease that you have not paid attention to them. So today we are going to discuss a little bit at length about these gestational trophoblastic diseases. I think within 1 hour you should get done. Okay, so just a matter of disclosure, today's presentation is sponsored by the Department of Reproductive Health in terms of the Zoom link and the SAT project, just for you to know. But we are going to have our discussion in this format. We're going to have a definition or different definitions that exist, and then we're going to look at classification and risk factors, and then as clinical practitioners, you need to know about pathogenesis. And to some of you who might be interested to dive deeper into pathology during your master's and all that, you will be first a lot with what we call histopathology or histopathological investigation that you need to know. So morphology come in handy. Then, last but not least, management and possible prognosis or follow-up. Very, very key for our discussion today. Yes, just a matter of definition, you know this already. You are all aware about this, that gestational trophoblastic disease is actually a spectrum of interrelated but histologically distinct tumors that originates from the placenta. And generally it is categorized by reliable tumor markers called human chorionic gonadotropins. We'll see how this comes in. There is what we call gestational trophoblastic neoplasia. And this is a subset of gestational trophoblastic disease that develop a malignant sequelae. So the malignant form that developed from gestational trophoblastic disease is called gestational trophoblastic neoplasia. And we will see how to do risk scoring for patients who are likely to develop gestational trophoblastic neoplasia. Now, but let's just go in that order of classification as well. Modified method of classification has been proposed by World Health Organization. And this divides gestational trophoblastic disease into molar lesions and non-molar lesions. For molar lesions, it's simply talking about identiform mole and invasive mole. Very, very, very interesting. Under this identiform mole, you're all aware it can be complete mole or partial mole. We don't have what we call incomplete mole. It's called partial mole. So it's something that you should not. In examination, many people like writing complete mole, complete identiform mole, and incomplete identiform mole. And yet I'm talking about partial identiform mole and complete identiform mole. So note this very, very well. Now, the non-molar lesions include the choriocarcinoma and epithelial trophoblastic tumor. Yes, this is the ones that are non-molar lesions that is known. Now, on the basis of epidemiology, it's sometimes important to understand what proportion of these conditions are there in our community. Yes, it is very, very important because we need to understand this and know that we need to focus our interest in this kind of condition. With complete identiform mole and partial identiform mole alone, yes, complete identiform mole and partial identiform mole. The identiform mole, the molar lesions called identiform mole, which is complete and partial, constitute about 80% of the cases of gestational trophoblastic disease. And these are the ones that sometimes progresses. Not all the time, but sometimes progresses. So the premalignant tumors, what we talked about as partial identiform mole and complete identiform mole, they have some low level of progressing to malignant transformation, especially the partial identiform mole. The likelihood of progressing is very low. Yes, the partial identiform mole, the likelihood of transforming into malignancy is just below 1%. Meanwhile, complete iontiniform mole, that you have always been evacuating in the hospitals, thinking it is a blighted ovum, thinking it is incomplete abortion, 15 to 20% likelihood of transforming into malignancy. And these are the patients that you should have to focus in the follow-up pattern. So this iontiniform mole can progress into invasive mole, can also progress into choriocarcinoma, and sometimes they develop placental trophoblastic tumors. Very, very key to know. Now, just to allude into this part of introduction, gestational trophoblastic disease, of course, we know already encompasses the tumors and tumor-like conditions that are normally characterized by proliferation of placental tissues, which has either the bilious and or the trophoblastic tissues. And the major disorders in this category, I already mentioned them, the different classification according to WHO. They have had what we call modified WHO plus different subtypes. The iontiniform mole, which has the partial or the complete, then invasive mole, choriocarcinoma, and placental trophoblastic tumor. Now, we are just going to make it easier by going to each one of those, because for understanding, you need to understand each of those, how they come about, and the morphology. So on the basis of the molar lesions, the first one is iontiniform mole. It is a neoplastic proliferation of the trophoblast, in which the terminal villi are transformed into vesicles. And when you look at that diagram, that picture there, it shows clearly a vesiced materials or tissues that has some fluid filled inside it. And that is actually important as when you're making diagnosis. Even if you're doing evacuation, you can look at these vesicles and actually know, oh, this is iontiniform mole. Yes, you can take this those samples that evacuated to the lab, to the pathology, but still they may confirm for you the same, because the appearance is actually typical. So you have the cystic swellings of the colonic villi that's accompanied by a lot of proliferation. So these cystic villi are many, and there are a lot of these vesicles that are there. So molar pregnancy can actually develop at any age, but we know very well that the risk groups are there towards the end of reproductive life. Those teenagers and those between the ages of 40 and 50 years, they are at risk of developing this condition. We already said that advanced maternal age in obstetrics is 35 years and above, but we're talking specifically about iontiniform mole. These age groups of 40 and up to 50, there are special age groups that studies have shown that they are at risk. And then, of course, we know everybody is at risk, because anyone can develop, any woman can develop molar pregnancy. Then the other thing is that two types of this, what we call the benign moles or molar lesions, the non-invasive one, the complete and the partial, what that we have been talking about. These factors, it is important to know, though we said all women are at risk, but others are more at risk. They even say others are more human than other people. So it is simply important to know that studies has revealed that there are certain age groups that are at risk, extreme age groups. I told you the younger one, the teenagers less than 20 years, and those with advanced maternal age more than 35 years. Obstetric history, a prior history of unsuccessful pregnancy. If you have had people having very many cases of spontaneous abortion, this doubles the risk of gestational trophoblastic disease in the subsequent pregnancies. And when someone has had history of pregnant gestational trophoblastic disease, one history of molar pregnancy increases the risk of the subsequent gestational trophoblastic disease in the subsequent pregnancies by 10 times. Two molar pregnancies in recurrent pregnancies actually increases the risk, the likelihood of the subsequent pregnancies with the molar pregnancy as well by 16 to 28%. You can imagine, this is too much. This is a lot of the likelihood of developing gestational trophoblastic disease. And that's why these patients need to still be followed up a lot. Other risk factors include smoking of cigarette, more than 15 cigarettes per day, but I don't think many people do this. Many women do this, but it's possible in some instances. Those people who are abusing the use of cigarettes, 15 cigarettes per day is at risk. Studies have actually shown it. History of infertility, irregular menstrual cycles, studies actually shown that these women are at risk. And then nulliparous women, people who are getting pregnant for the first time, the likelihood of being exposed for the first time to the paternal antigens predisposes these women to gestational trophoblastic disease. The use of oral contraceptives also has been noted to increase the risk because these are hormonal drive. So if you are using oral contraceptives, the likelihood of being a risk factor is there, but not the cause. It's a risk factor in this case. Then when we're talking about complete mole this time, complete identity-form mole results, how does it come about? It is very important to know this because in your practice, you will see different structures. And this diagram actually illustrates how the appearance look like. Yes, complete identity-form mole results from fertilization of an egg that has lost its fetal or female chromosomes. So when the female chromosomes are lost, the resulting genetic materials is only from the father or from the man that is paternally derived. And that's typically how it looks when you evacuate. Now, this is just to illustrate to you how these things come about. But still the same thing. When you have a complete mole, you can have this sperm fertilizes an egg without its genetic component. So what is remaining there, what is taken there inside the empty ovum is only from the paternally derived. So you can have duplication taking place to try to form or to mimic the normal chromosomes that a normal embryo should actually have. What we call the homozygous complete mole, we have 46XX. This is just a duplication. If the sperm is X, having X chromosome, fertilizes an empty ovum, you will have duplication taking place, and you'll have 46XX. And this is the commonest cause of complete identity-form mole. Up to 90% have this kind of format. But 10% can result from fertilization of an empty egg by 2 sperm. This time, there is no duplication of the chromosomes to make the 46 as a normal chromosome. So you don't have any duplication. What happens is that 2 sperms may contain X, there may be a 23X or a 26, a 23Y, and they fertilize an empty ovum. They don't undergo duplication. What will result will still be a complete identity-form mole. In this case, when you have the 23, it's not indicated here in the diagram, but I must tell you, when you have 23 YYs, for example, a 23Y sperm and another 23Y sperm, fertilize an empty ovum, you are supposed to result into a 46YY, which I have not indicated there. Now, this kind of chromosome complex do not survive. They are very lethal, so that's why I have not even indicated the diagram there. But actually, that's another variance. Now, the pregnancy will get lost without it being noticed early enough. So you will not see these things of complete identity-form mole because they get lost as the menstrual flow so early enough without anything being formed. Okay, so we can have in a complete identity-form mole, the embryo normally is not there. So normally you'll not be able to see any embryo. So the patient have the risk of developing choriocarcinoma though. And sometimes also the risk of developing the malignant form of what we call gestational trophoblastic neoplasia is there for complete identity-form mole. What about for partial identity-form mole? It results from fertilization of an egg with 2 sperm. This time, the chromosome, the maternal chromosome is not lost, it's also present. But we have 2 sperms that fertilizes what? An egg. And so you have what we call a triploidic kind of chromosomal arrangement. And this is just typical structure of a partial mole. The good thing with the partial mole, you may be able to see some fetal tissues. And when you do histopathology, you'll be able to see some fetal tissues. But this diagram is showing us the macroscopic, you can see with your eyes. It's not the pathological stain or some tissues that are already. It's just a tissue that you can see with your eyes. This is typical appearance. You can be able to see even the fetal tissues in it. I told you with complete identiform mole, there is no fetal tissues. Now, sometimes partial moles have some level increase of actual progression into other persistent molar lesions, but not normally associated with choriocarcinoma. So the likelihood is very low, and it's not been associated mainly with choriocarcinoma. It's only the the complete identiform mole. This was the diagram I want to also show you, that two sperms fertilizes an ovum, which is also having its chromosome. Unlike for complete identiform mole, the ovum has lost its chromosome. This time it has not lost it, so we have the triploid kind of arrangement of the chromosome that is resulting. I've already told you, when you have a double Y in the complex, in the chromosome complex, normally they don't survive. So even this one that I've shown you, 69XYY, yes, may not necessarily exist. So they're very rare. They don't actually most time exist. They are lost so early enough. So what you may even be able to see in partial mole, many of them are the 69XXX and 69XXX or 69XXY. And that's the complex we are talking about. The morphology, this is sometimes how you can see the tissues with fetal tissues being present. The classic appearance of this is delicate fibrous mass with thin wall and translucent. You cannot see through. Unlike for the other one, you may be able to see through. Then they are cystic in nature, and you can look like a grape. So this is what it means in the morphology. When you do the evacuation, you automatically see some of these things easily. I told you we may not necessarily stop there, but these pathologists will give us their findings. They may report, even you can see macroscopically a bunch of grapes with appearance clusters of vesicles. And you can then be able to see some fetal tissues. And sometimes a molar pregnancy can exist with a live fetus. For example, you have twin pregnancies. One is a molar pregnancy, the other one is a live fetus. These pregnancies will allow them to progress through until deliveries. Then you deliver both. You will deliver the molar pregnancy at the same time also deliver the what? Deliver the live baby, and there will be no problem about it. So that's what I can add to you, because those are not very rare cases. They are there that can appear. You can have existence of a molar pregnancy and also a case of a live fetus, especially the partial identiform mole. Very good. But these pathologies normally report to you microscopic appearance as well. They will report this classic triad for complete identiform mole: a vascular villi, nest of prophylactic syncytiotrophoblasts and cytotrophoblasts surrounding the villi, and also edema of the villus stroma. So when they give you this classic triad, just make a diagnosis of complete identiform mole. And this is a staining appearance by the pathologist. You can see a nest of the trophoblasts. These are the villi. This projection towards the inside, they are the villi. They are the villi that you can see, nest of villi there. This is just what they're trying to show you. And you can see the villi are big, this one here, and this other one here, they're big. The pathologists explain this more thoroughly well. So they are very big. That's the edema within the villi that they're telling you about. So for partial identiform mole, macroscopically, they are variable. We said there could be placental tissue, there could be fetal tissues that are present, but sometimes the fetal tissues may not be present. And that's why we encourage that all the time when you have done evacuation, take this tissue for pathology to diagnose, to say this is partial, this is complete, but others are obvious. The complete identiform mole may be obvious, even the partial, but still, pathologists are required to make diagnosis. And I think you guys should venture into this. If we have one pathologist here in Gulu, we could actually say, okay, let us do a study and see the prevalence of pathological diagnosis, partial mole or gestational trophoblastic disease among people attending gynecology ward at Guru University Teaching Hospitals. That is Guru Referral and St. Mary's Hospital Lecture. So that is your MEd thesis already. Very big thing. Microscopically, for partial identity mole, unlike the cases of complete identity mole, where the villi have no vessels, sometimes with this, because they are fetal tissues, you could have blood vessels present and may contain normal appearance of the villi, and fetal tissues may be present. So the hydropic changes may be variable depending on how the partial mole is. Now, mostly present in this case, partial moles normally you may have spontaneous miscarriage or abortion that takes place, and people normally do curetage in many cases, many instances, without knowing, even for complete identified mole. And you notice during that time of evacuation. There's something to note here is that in complete moles, human chorionic gonadotropin levels greatly exceed those of normal pregnancy. Very key. So when you have serum human chorionic gonadotropin levels that exceed even normal pregnancies, and the rate at which the human chorionic gonadotropin rises over time may be abnormal. For example, every week, every week, the levels of human chorionic gonadotropin should be doubling in pregnancy. But when you find tripling or quadrupling, then you know this may be abnormal pregnancies. Even if it is a multiple pregnancy, when we have complete identity mole, the levels of human chorionic gonadotropins even rises above the levels of the rise of human chorionic gonadotropins in multiple pregnancies. So this is very, very distinct that you should actually get to know. Of course, the symptoms that may manifest early enough, because you have high level of human chorionic gonadotropins in this patient that are rising rapidly, you can have severe nausea and vomiting. And some people call it hyperemesis gravidarium. So this patient needs to be evaluated. Ultrasound scan is key, should be done. Because in the treatment, you need to successfully remove, if it is what? A molar pregnancy by curettage. And sometimes when the cervix is closed, you do dilatation and curettage. So the patient are subsequently monitored for about 6 months for all cases of identity mole, and to ensure that the ACZ level reduces to non-pregnant state after the termination of that pregnancy. So monitoring is key. It should be noted that some of the monitoring can go as long as up to even 1 year, because if it is a complete identity mole, the time when someone gets pregnant in subsequent pregnancies, the development of invasive mole choriocarcinoma or gestational trophoblastic neoplasia is even more common, because they can develop up to the rate of 15% in many cases. So choriocarcinoma is something very dangerous, but also the good thing is we can treat. So this patient with complete identity mole and increasing or elevating level of human chorionic gonadotropins needs to be monitored, especially when someone has had complete identity mole, because the likelihood of developing choriocarcinoma is also there. Now, basically, that is briefly on what we call the molar lesions as far as identity mole is concerned. For us to cover all, we need to go a little bit in steps. Let's look at invasive mole. For invasive mole, is a molar lesion that normally can penetrate or even perforate the uterus or the uterine wall. It's something that you must know. There is invasion of the myometrium by hydrophic chorionic villi, and this accompanied by proliferation of both the cytotrophoblasts and sensotrophoblasts, which I think you have learned in the basic sciences. So the tumor is locally destructive or invasive. That's why we call it invasive mole. So it can invade up to the myometrium, up to the serosa, even up to the parametrial tissues, and invade some of the blood vessels surrounding parametrial areas, like the uterine vessels. So it is very, very dangerous. Hydrophic villi may embolize to distant sites, example, the lungs and the brain. They are not very common with invasive mole, because invasive mole normally have local invasions. So the likelihood of the metastasis is low, but it can actually happen in some instances. Yes. But with invention of chemotherapy, we can actually manage this, and then this patient will get better in most cases. So the tumors or this condition may manifest as vaginal bleeding or irregular uterine enlargement. So this is a trigger for you to examine this patient very well and do ultrasound scan as well, which is one of the gold standard in the initial diagnosis because they are relatively available in our setting. So of course, other markers could guide you a high level of human chorionic gonadotropins, and sometimes some of these tumors may not respond well to chemotherapy, and it is important. So that's why sometimes we can be able to do even hysterectomy in order to manage to remove all the tumors to prevent more invasions to other structures. What about choriocarcinoma? Choriocarcinoma, in this case, gestational choriocarcinoma, because we can also have what we call non-gestational choriocarcinoma. And non-gestational choriocarcinoma occurs in children. The children who can develop choriocarcinoma as well. But this one here, we're talking about pregnant women. Someone gets pregnant and develops choriocarcinoma. So it's a sequelae from progression from complete identiform mole to invasive mole or to choriocarcinoma directly, which is a malignant neoplasm of trophoblastic tissues. And we know very well that choriocarcinoma is rapidly invasive and can metastasize to other organs. But the good news is it can respond very well to chemotherapy. And just a little bit of the incidence, just to know the epidemiology kind of stuff. Yeah, I will not take a lot of time here. Choriocarcinoma is not very uncommon. It can actually occur, but I'm not going to take a lot of time in this. This is the diagram. You can see that picture is clear. When you see some pictures like this, think about choriocarcinoma. It is soft, fleshy, yellow-white tumors. Usually have some large pale areas. You can actually see it very clearly in the slide. Large pale areas, this other one here. Yeah, these tissues are soft and fleshy. So you have yellow-white tumors, these yellow-white tumors that you can see. So they have areas of necrosis and extensive hemorrhage. This area here, you can see extensive hemorrhage and getting necrotic. Very clear. But pathologists normally will give you this other finding that it does not have chorionic villi. They will say absent chorionic villi and consistent with just the structures that proliferate with sensitive trophoblasts and cytotrophoblasts. You can see this staining. The pathologists always learn this even more. But for your case, you just need to know that there is absent chorionic villi in choriocarcinoma, unlike in the other GTDs. Very, very important to know. That's a very big difference when they report to you. The abundant mitosis, yes, and the pathologist will tell you the abundant mitosis and can even tell the tumors as invaded and involve some other structures, frequently involving the blood vessels, uterine serosa, and adjacent structures. But even more seriously, it can embolize to other organs. The commonest is the lungs. So clinical features, just like others, you have irregular vaginal spotting or bleeding with brown fluid that you will be able to see. And sometimes we can get this patient like another case of incomplete abortion, and yet it's choriocarcinoma. So it is very important for us to know. And sometimes we can diagnose this when you take all the samples for, all the curated sample for pathology. We'll be able to have this done. Sometimes the tumors may not appear immediately, but can take some duration of months, even up to a year for it to appear when someone gets pregnant. So the most important thing is the spread. The most commonest modality for the spread is hematogenous. So it can dislodge to the lungs, and that's the commonest organs for metastasis, the lungs. But with X-rays available, when you do chest radiographs, you'll be able to see metastatic lesions within the lungs, and that will be able to tell you how serious the tumors has gone. As I told you, you know very well that in the management is a little bit better, but this slide is to show you metastasis, now to the lungs is the commonest, 50%, followed by the vagina, 30 to 40%. So when you find a mass within the vagina that looks like, maybe you think of CA cervix, CA vagina, please don't forget about our choriocarcinoma as well. Other organ system that normally it goes to can be the brain in that order, liver, bone, kidneys. But these two, vagina and the lungs, most common. Now, the treatment depends on the stage of the tumors. Usually, it consists of if you have an identiform mole, if it is just identiform mole, normal evaluation, the evacuation of uterus is key. But if you have choriocarcinoma now, you have to intervene and give chemotherapy. And it's very nice. Chemotherapy has been noticed to reduce or to manage these cases up to remission. So it normally cures it, and what we call 100% remission. And the high cure rates are there. What about placenta-site trophoblastic tumors? One of the non-amolar lesions. This comprises about 2% of the GTNs, the gestational trophoblastic neoplasia. So they are just proliferation of extravillous trophoblasts, and sometimes it also involves the intermediate trophoblasts. So in normal pregnancy, the trophoblasts are normally found in non-villous sites, such as the implantation sites, islands of cells within the placental parenchyma, and even in the placental membranes. But in the case of placenta-site trophoblastic tumors, the terminal or the intermediate trophoblasts ovuli can actually proliferate and cause this trophoblastic, what we call the placenta-site trophoblastic tumor. So the normal extravillous trophoblasts are normally in this kind of shape. Normally, these people describe, the pathologists describe when you give them the samples. They won't normally describe it, so I don't want to take long into that. So the presence of placenta trophoblastic tumors may be noticed as a uterine mass. So you can have these accompanying symptoms: abnormal uterine bleeding. Of course, these patients would be amenorrheic, and sometimes the level of HCG may not be so much elevated, may be moderately elevated. But histologically, placenta-site trophoblastic tumor is composed of malignant trophoblastic cells that normally diffuse within the endomyometrium. So that's how serious it can be. It may follow normal pregnancy, or may follow spontaneous abortion, or may follow irritative mole. More commonly, the complete irritative mole. And the patient may have localized disease in some instances. 10 to 15% of women normally die from disseminated disease. Now, when you have placenta-site trophoblastic tumor, in most cases, is an indication for hysterectomy. In fact, total abdominal hysterectomy. Yes, total abdominal hysterectomy is one of the type of hysterectomy, which is type 1, type 1, type 1B. Type 1A is subtotal or supracervical. Very good. So indication for hysterectomy in gestational trophoblastic disease or tumors, one of them when you have placenta-site trophoblastic tumor. And sometimes you do hysterectomy in patients with other form of gestational trophoblastic disease when they have intractable hemorrhage. For example, you're doing evacuation and the bleeding refuses to stop, and you have intractable hemorrhage. The blood is pouring. You don't want the woman to die, so you convert. And that's why dilatation and curettage should be done in theater. When you have intractable hemorrhage, you have to intervene by doing hysterectomy. Sometimes we can do hysterectomy in patients who have met the family size and then have a localized disease. So gestational trophoblastic tumors in a patient who is para 9 plus 0, para 8 plus 0, para 6, and they say that number of children they have is enough, and they have localized disease, please, better do hysterectomy to prevent monitoring and having all this sequelae that can result in gestational trophoblastic neoplasia. And I think briefly that's what I want to discuss with you at the level of MBCS 5. Thank you very much. I would welcome some few questions. I know time is not on our side, but we try to manage it. Any question, please?